I guess Dr. Wang and myself don't have anything to disclose. Dr. Weiss is a PI and a co-investigator on research grants from Brilliant Sciences. At the conclusion of today, we're going to be able to, we hope you'll be able to discuss evidence-based treatments for substance use disorders, including alcohol and opiate use disorders that can be used in the primary care setting, and then identify ways in which primary care providers, such as ourselves, can contribute to reducing morbidity and mortality associated with the opioid crisis. I'm going to be starting off with alcohol use disorder, and followed by Dr. Wang, who's going to be talking about opiate use disorder, and then Dr. Weiss will bring us all together in terms of models of care. So alcohol use disorder treatment, otherwise known as AUD, it's been around for, alcohol use disorder has been around for a long time. Like the Greeks had a god dedicated to alcohol drinking. And so it's not a lot has been updated in the last 5 years. Although this study from the National Epidemiologic Survey on Alcohol-Related Conditions showed that the alcohol incidence and prevalence of alcohol use disorder has been steadily increasing since 2001. The biggest increase is in alcohol use disorder, and in 2013 there was about a 50% increase overall. The greatest increase were among women, older adults, racial ethnic minorities, as well as people with lower educational level and family income. I highlighted this, oops, I turned that off, I'm sorry. So I highlighted this, it's a 106% increase in alcohol use disorder in patients over 65. So our older patient population is particularly vulnerable to alcohol use disorder. The definition of alcohol use disorder has also changed since 2013. It used to be classified under alcohol use dependence and alcohol abuse under DSM-4. Now it's all sort of classified as one disorder, as alcohol use disorder, and broken up into gradients of mild, moderate, and severe based on the number of symptoms. The DSM-5 lists out these symptoms that we should be all looking for. Two or more of the following symptoms in the last 12-month period is considered positive for alcohol use disorder. Now, of note, in our clinic, we do expert screening, and I'll talk a little bit about that. But expert screening is just a screening tool to identify high-risk or at-risk drinking behaviors. It doesn't necessarily diagnose someone with alcohol use disorder. So when we use the audit C, and it comes back as positive, I think it's wise to follow up with questions that go along with the DSM-5 definition of alcohol use disorder. Once identified with alcohol use disorder, as primary care doctors, we have a lot at our disposal to offer our patients. We can refer for inpatient detoxification. We can also refer out for inpatient and residential rehab programs. The data for these two modalities of treatment are mixed, so I'm not going to particularly talk about them today. We also have at our disposal psychosocial interventions. We don't necessarily need to refer out for psychosocial interventions. There's been data to suggest that even brief interventions in the clinic, 5 to 15 minutes of counseling with a patient, has been shown to be effective in reducing alcohol intake for our patients. There's also medications, and I'll talk about them in depth. And the most recommended treatment is, of course, a combination of psychosocial interventions as well as medications. And that's been the most researched. In terms of psychosocial interventions, there's a variety of options: cognitive behavioral therapy, motivational interviewing, 12-step support groups, and contingency management. Now, the vast majority of these interventions are aimed at helping our patients develop coping strategies for when there's triggers, as well as when there's cravings for alcohol drinking. The evidence for the efficacy of these interventions replicated over a couple of handful of studies, well-validated studies. The problem is with the psychosocial interventions, just the responsiveness is very variable. So some people do really well with motivational interviewing, some people do less well. So in terms of expert, like as we talked about, in our clinic we are doing that. Expert is the screening, brief intervention, and referral to treatment. And we have a protocol to do the screening questions. There's one for alcohol, there's one for substance use. If the screening questions that the MA asks are positive, it's going to be flagged. The recommendation is to follow up with an audit C for alcohol and a DAS-10 for substance use. And if those are positive, and based on how positive, like it's mild, moderate, or severe in terms of the audit C has a breakdown of that, then the recommendation is, if it's mild to moderate, a brief intervention in the clinic and referral to treatment. Now, the studies that validated expert, in fact, recommend multiple applications of brief interventions and brief treatment. So these the brief interventions is defined as 1 to 5 sessions lasting 5 minutes to an hour. So it's not a one and done deal where you like say, hey, you have a drinking problem, work on that, and then forget about it. It is repeated counseling over multiple sessions, and that's been shown to be most effective in alcohol use disorder. There's been some data to say that it might be effective in drug use disorder, but still working on that data. Current FDA-approved pharmacotherapies for alcohol use disorder, the most, I guess the oldest is Disulfiram, which was approved in the 1950s. It's sort of a deterrent medication rather than a prevention medication. It inhibits acetaldehyde dehydrogenase, and it leads to aversive symptoms. Followed by naltrexone, approved in the 1990s, and then acamprosate was the most recent in 2004. We also recently, I guess in the last 5 years or so, have had naltrexone IM as an option for long-term maintenance for alcohol use disorder. So Disulfiram, as I said, it's been approved for around since the 1950s. It blocks the metabolism of alcohol so that there is a buildup of acetaldehyde in our blood, and that leads to a very uncomfortable syndrome called disulfiram ethanol reaction. So you get skin flushing, hypotension, tachycardia, nausea, vomiting, dizziness. You know, anyone who's had alcohol toxicity can tell you it's not a pleasant sensation. So it's really a deterrent medication. It lasts about 30 minutes after, these symptoms start and then it lasts about 30 minutes after consumption. Now, disulfiram is long-lasting. It stays in our system for quite a while. So even if someone stopped taking disulfiram and then they have a drink about 2 weeks later, they can still get the disulfiram ethanol reaction. Contraindications for disulfiram is anyone obviously who's been recently drinking or continuously drinking, and then it's hepatically metabolized, so LFT should be monitored, especially during the initiation phase and then as you go along in maintenance. Disulfiram effectiveness has been validated in a number of studies, although there's been criticism as to how these studies were designed. A lot of the studies were randomized controlled trials with two blinded arms. So the patient didn't, or the participants didn't know if they were getting disulfiram or placebo. And that is counterproductive in terms of like how disulfiram works. If they know that they're taking it, it's sort of a deterrent so that it's less likely to drink. But because of these studies, because of the mixed results of these studies, the American Society of Addiction Medicine does not recommend disulfiram as a moderation treatment. So if you're trying to get your patient to cut down on drinking or to reduce the frequency of drinking, it's probably not the best maintenance therapy. And then the issue with abstinence is that a lot of these studies, their endpoint was abstinence, so total abstinence, and it raises the question is, do we really just want abstinence for our patients? Is there another endpoint? So a study done by the VA in 1980s showed that there was a subset of patient population that they continuously surveyed for, I think, 2 years after the study was concluded. And they showed that a number of the patients relapsed back to drinking, but on Disulfiram, the people who relapsed actually drank less in terms of the amount consumed, but also the number of days spent drinking. So there might be some use in Disulfiram to reduce drinking frequency. Now, camprosate is the second medication that's been FDA approved. It's an amino acid derivative, increases GABA transmission, does a lot of things, but in actuality, what it's hypothesized to do is it decreases the reward pathway in our brain, so it reduces cravings and reduces the reinforcement of pleasure from drinking. It's renally cleared, so it's contraindicated in patients with end-stage renal disease, but because it's not hepatically metabolized, it is okay to use in decompensated cirrhosis. So this is actually a really good option because a lot of our patients who are lifelong alcoholics have a tendency to have severe liver impairment. So this is a good option. One downside to camprosate, though, it is 2 pills 3 times a day. A lot of pills for our patients to take, and sometimes that's a turnoff for our patients. Common side effects are diarrhea and skin pruritus. Although I've noticed that for a number of our patients who are on it, it's very transient within the first month or so, and it kind of goes away. Now, Naltrexone, I think Linda's going to talk a little bit about it in the context of opioid use disorder, but it is also FDA approved for alcohol use disorder. It's an opioid antagonist, but again, like a camprosate, the hypothesis is that it does something to the reward pathway in our brain, so it decreases the reinforcement of that pathway. It decreases cravings, it decreases the pleasant experience of intoxication, and then reduces that reinforcement, as I said. It is hepatically metabolized, and there is a label warning in terms of hepatotoxicity. So you should get an LFT before initiating and then follow the LFT pretty regularly once on treatment. Obviously avoid when someone's in acute hepatitis or acute liver failure, and then if symptomatic. The FDA-approved dose is 50 milligrams. That's the dose we normally use in REACH. Although studies have shown that you can go up to 150, it probably doesn't affect that much. Side effects, there are a number of side effects with naltrexone, mostly GI side effects, so nausea, and then dizziness, headaches, lightheadedness. If people tolerate naltrexone PO, and we normally start naltrexone PO for about 2 weeks to a month, and if the patient tolerates it well and they want to continue treatment and are engaged in treatment, we will switch over to the monthly IM injection. There's a paper in JAMA in 2014, I think does a really comprehensive review of the effectiveness of naltrexone and camprosate. In general, it does look at the studies from the standpoint of abstinence, in terms of, and then also from the standpoint of reducing just frequency of drinking and volume of alcohol. In terms of total abstinence, the number needed to treat to prevent one person from returning to any drinking was 12 for camprosate and 20 for naltrexone. So from a standpoint of just abstinence, if that's all we're looking for, seems like a camprosate works a little bit slightly better than naltrexone. However, if we're looking at just in terms of reduction of drinking as a moderation approach, then naltrexone definitely is much more effective in reducing drinking behavior. So number needed to treat for naltrexone is just 12 in this case. We have other pharmacotherapy options that have been studied and have been used off-label for alcohol use disorder. I think we're familiar with gabapentin, Topamax, baclofen, and valproic acid. Now, a vast majority of the meta-analysis I looked at said none of these actually work that great, so I'm not going to talk about them. I'm going to just one exception, though, is topiramate, which actually has really good data to back its effectiveness, and then possibly valproic acid in situations where patients have concomitant bipolar disorder. There were 2 very good randomized controlled trials that showed that it works pretty well. For topiramate, it's a mixed AMPA glutamate antagonist. It basically enhances GABA function, inhibits carbonic anhydrase, and it inhibits excitatory calcium and sodium channels. There's been studies, I guess genetic studies, to show that there is variability in response based on allele, the homozygotes for the RS283-2407 allele of GRIC1. I'm not a scientist in that sense, so this was all interesting to me, but it's probably going to play a role later down the road when we're thinking about individualized medicine for our patients. Side effects for topiramate is actually one of its most limiting factor. It has well-documented side effects of memory deficits, somnolence, and then increased risk of suicide and sedation. And so the recommendation for topiramate is to start at 25 and slowly ramp up to a maximum of 300 milligrams divided over multiple doses throughout the day, so twice a day or 3 times a day. It's currently not FDA approved for alcohol use disorder, and it's likely not going to be FDA approved only because it's been off patent for a little while, and so the FDA don't normally reconsider medications that's off patent. But it's been endorsed by the National Institute on Alcohol Abuse and Alcoholism, and it's the most prescribed medication for alcohol use disorder in the VA system. The efficacy has been demonstrated in 7 randomized controlled trials. It showed the effect size was moderate for topiramate in terms of abstinence and reducing alcohol use, and then it's a comparable effect size for naltrexone and cannabis. On the horizon, there's been a number of animal studies that haven't made it to human studies yet, targeting different drug targets in the brain. Most of them are to target the motivational and reward pathway, and the studies look promising, but not yet, like I said, translated to human clinical trials yet. Further research is obviously necessary to help us augment our armamentarium. So we know we have these options, but how do we get them to work together in a way that's meaningful and effective for our patients? So individualized therapy either through genetic markers or psychosocial predictors, and then thinking about the intersective personality factors as well. We also need research on novel care delivery systems, so how do we get our patients to be more engaged? Maintenance is an issue. A lot of these studies were for a short period of time. How do we get our patients to engage over a longer period of time? And then redefining treatment success. Should abstinence be all that we care about? How do we define treatment success? All right. So, oh yeah, and then this is one slide just to remind us that substance use in general is a chronic disease. And when we talk about relapse, we think of it in the terms of failure. But in actuality, we compare the number of patients who stop and start and restart medications for hypertension and asthma and have so-called relapses for hypertension and asthma. Substance use disorder relapse is actually lower than that, so that's just something to consider. All right, let's go with something.
Okay, thanks, Trang. Okay, so I'm just going to focus on opioid use disorder treatment. So we have a couple of pharmacologic treatment options. I'm sure everybody is aware. There are opioid agonists and opioid antagonists, which Trang already mentioned as being naltrexone. In terms of agonists, we have buprenorphine and methadone. And then, just to point out that pharmacologic treatment is more effective at reducing illicit opioid use than no medication or placebo. And overall, methadone and buprenorphine tend to reduce overall mortality in addition to opioid-specific mortality. And maintenance treatment is more effective than detox. I'm not going to show any slides on epi, but I'm sure everybody's bombarded every day on the media by how the opioid epidemic is not really ceasing. And so just so you guys know, it hasn't really dropped any significantly, and we still have an issue in New York City and also across the country. There is non-pharmacologic treatment, similar to Trang. I'm not going to spend any time talking about it because there's limited data on its efficacy. So similar to alcohol use disorder treatment, you have rehab, residential treatment, intensive outpatient treatment, and the self-help 12-step groups. I do want to show one study that was recently published, I believe it was last year, that came out of Boston. They have this great system there where through like a law that was passed a couple years ago, all of the governmental data sets and the private data sets get combined. And so researchers and academics can actually utilize all of these large data sets to sort of look at trends in morbidity and mortality related to substance use and find new policies that could help increase access to care. So this was a cohort of about 17,000 patients in Massachusetts between 2012 and 2014, and they looked at these people who had a non-fatal overdose. And they then tracked them out over 12 months to look at receipt of medications for opioid use disorder treatment and also mortality. And they basically found that the all-cause mortality rate was about 4.7 per 100 person years. And then in these Kaplan-Meier curves, they showed that buprenorphine and methadone were associated with reductions in all-cause and opioid-related mortality. Unfortunately, naltrexone was not, and so we don't really have good mortality data on naltrexone yet. Just another point to note that came out of this study is that about 30% of participants in the cohort who had experienced a non-fatal overdose did not actually they did receive treatment, but the vast majority did not after they experienced an overdose. So only a minority of patients actually got treatment. So this is just a comparative graph to note the differences between buprenorphine, naltrexone, and methadone. I'm not going to spend much time talking about methadone because we don't really do it in a primary care setting. So buprenorphine is a partial agonist compared to naltrexone, which is an antagonist. Both of them require that you are in an opioid-free state to initiate. For buprenorphine, we have it in like the sublingual forms, films, and tablets, and there's also an implant that recently just came out, and we're sort of looking at the efficacy of the implant. It's co-formulated with naloxone, and it is metabolized hepatically by the liver. There is no known cardiac toxicity, and compared with methadone, buprenorphine does not prolong the QTc. And its risk of respiratory sedation is pretty rare unless you mix it with CNS depressants like alcohol or benzodiazepines. Naltrexone, as Trang had mentioned, is an antagonist, and we have oral and intramuscular formulations. We can use both for opioid use disorder, but as I kind of mentioned earlier, we don't really know if it's more effective or less than buprenorphine and methadone. It seems to be a little less effective, but maybe good for patients who are really highly motivated to not use it all. Because if you do take naltrexone, you basically lose all of your opioid tolerance, and that's pretty vulnerable for a lot of patients. And then methadone, which I'm not going to go into detail, is obviously highly effective. And most of the research that's been done on OUD treatment look at methadone in terms of its impact on morbidity and mortality. The one downside, obviously, is that it is an agonist. And so as you give higher doses of methadone, you will get more of an effect. And so you have a higher risk of respiratory sedation, and it does prolong your QTc. In terms of treatment delivery differences, I would say that this is probably the biggest difference between the agonist and the antagonist. Methadone is really highly regulated, and it's only in the OTPs. We don't do it here at all. You can prescribe methadone for chronic pain, but you can't do it for both chronic pain and opioid use disorder. You have to get it in a regulated setting. But buprenorphine is pretty minimally regulated, and naltrexone is just not regulated at all. For buprenorphine, that means you need to get an 8-hour training that's done through the New York Department of Health or any other affiliated organizations, and then you get an X number. Some of you guys have that already, which is great. The medication can be dispensed through a community pharmacy. You can actually get refills with buprenorphine since it's a differently scheduled drug, and this is different when compared with oxycodone or any of your other full opioid agonists. The visit frequency, so when we see patients at REACH, initially patients will come on a daily to weekly basis, and then as they do better on a titrated dose, we sort of tailor the follow-up visits to their needs. Oftentimes patients come anywhere between every 2 weeks or every 4 weeks for follow-up with either myself, Trang, or Stacy, our buprenorphine nurse care manager. Naltrexone very similarly can be dispensed at a pharmacy in the community with refills, and visit frequency varies from weekly to monthly. In terms of efficacy for buprenorphine, retention is generally pretty good, although some of the studies suggest that it's slightly lower at lower doses. And then naltrexone, in terms of the retention, oral is definitely better, not much better than placebo, and the extended release tends to be more efficacious overall. So I think that's a little bit different than alcohol. We really don't know if the oral naltrexone is very efficacious for opioid use disorder. But definitely being on some kind of treatment is better than nothing. And then methadone is higher retention, probably related to the treatment structure of the OTP. In terms of suppression of illicit opioid use, all three of the medications do suppress opioid use. In terms of mortality reduction, we have data that suggests that just buprenorphine and methadone substantially reduce mortality, greater than 50% compared to placebo. But we don't have that data for naltrexone. So for buprenorphine treatment in primary care, we know that it's feasible in an office-based setting. We've been doing it for the past couple of years. We are seeing nationally that an increasing number of primary care providers are becoming waiver to prescribe. We actually have an upcoming training at Sinai on May 6th, 1 p.m. So if anyone is around and interested, feel free to come. And then we do have evolving practice changes as we learn more about how to do buprenorphine treatment in primary care, just in response to some of the newer evidence. And also, there's a very large push at the local level and national level to expand treatment and respond to the ongoing number of overdose deaths. So I'm just going to spend a little bit of time talking about some of the evolving practice changes that we're hoping to implement, not just in our program, but also we're seeing it across the country as well. So this was an article that came out, I think this year recently, talking about sort of what are the next steps in buprenorphine treatment in the care of patients with opioid use disorder, looking at all the different previous approaches that we used to do in the office compared with some of the newer findings and recommendations. So I'm just going to go through some of these. So in our previous approach, we sort of considered a medical setting as being necessary for buprenorphine induction. So actually bringing patients into the office and the clinic, watching them take their first dose as they're in withdrawal. So we don't really do that anymore, and I don't think we've ever done it here at IMA. I can't imagine doing it at IMA given our space limitations. But so really the studies over the past few years have shown that home induction is safe and effective, and that's sort of the gold standard. Office-based induction is often a barrier to treatment. A lot of our patients don't want to come to the clinic when they're having diarrhea and they feel terrible. Cohort observational reviews showed no adverse effects with home induction, especially when you provide appropriate patient education and follow-up support. So Stacy, our nurse, actually spends a lot of time with the patient sitting down to go over exactly how to take buprenorphine, giving them handouts and also checking in with them throughout the week as they start it. And then it's hard, similar to the CWA protocol, I think, to find the staff and the people to actually monitor these patients over time. There's a clinical opioid withdrawal scale, which is similar to CWA, where you sort of check off all the patient's symptoms, and it's really challenging to do. So logistically, I think it's a bit of a nightmare, so we don't do that anymore. Okay, so next, we used to think that benzos and buprenorphine are a toxic combination. So there's mixed data about this, but essentially, we know that dual prescribing is really prevalent in the country. About 17% of patients who get buprenorphine also are prescribed benzodiazepines as well. Data from the VA suggests that that percentage fluctuates anywhere between 11 and 35% in that population. So it's pretty common. In post-mortem toxicology results, buprenorphine is found in less than about like 2% of the deaths that are related to overdose. And then oftentimes what we'll see is that patients have been taking benzos that have been appropriately prescribed for many years without misuse. And we find that tapering patients who've been on a stable dose of like 2 milligrams or 3 milligrams of clonazepam is probably more destabilizing to these patients. So we don't actually taper them before we start buprenorphine, and we just continue it. Some of the studies suggest that the higher risk is associated with some of the shorter acting benzos like alprazolam. And obviously benzos and opioids that are full agonists confer a higher risk. But because buprenorphine is a partial agonist, it does seem to be less risky in terms of respiratory sedation. So the new recommendation is really to not withhold buprenorphine because somebody is taking benzos, and that the benefits of treating opioid use disorder with buprenorphine really do outweigh the risks of concomitant use of these medications. Another thing we used to do is consider experience a relapse of failed buprenorphine treatment. And in fact, a lot of patients nationally who had at some point gotten buprenorphine are often taken off of buprenorphine because they've returned to use. And so Trang mentioned this, but long-term or complete abstinence from opioid use is really low. And so there was a cohort review that showed that less than 30% of patients over like 10 to 30 years actually have complete abstinence. So iterative relapse is really common, and it should be expected. And I think, you know, we all see that in other chronic illnesses like diabetes and hypertension. And the WHO estimates that long-term adherence to therapy for diabetes and hypertension is about 50%. So I think moving forward, we're really trying to push for the analogy to other chronic illnesses when we sort of think about and manage substance use disorders, because it is really very much like a chronic disease. So patients who do experience relapse should just be given additional support and resources rather than cessation of treatment. Unfortunately, we see a lot of patients who come to us from other programs whose providers have actually stopped their treatment because they, you know, intermittently use heroin. So I don't know how many of you guys here have patients that we co-manage, but it's very common for us to have reach patients who are still intermittently using heroin and still intermittently experiencing non-fatal overdoses while they're on buprenorphine. In general, our thought is that these patients actually do much better if they continue to follow up with us and stay engaged in treatment as much as possible. Okay, in the previous approach, we also used to think that traditional counseling is needed to benefit from buprenorphine treatment. So there was a systematic review. I'm not going to show the data for it, but psychosocial counseling with treatment didn't really confer any additional benefit than with the concurrent psychosocial intervention. So really, we think that you just need to be on the medications. And some people actually do really well and really like counseling, but it shouldn't be mandatory. Unfortunately, in a lot of other states, not like New York, insurances do mandate that patients receive psychosocial counseling in addition to medications, which is unfortunate because I don't think everybody needs it or wants it. And so we really, you know, are of the mindset that you can offer it to patients who really think that they might benefit, but really it should not hold someone back from engaging in medications for OUD treatment. And the WHO actually has sort of flipped how we think about medications for addiction treatment. So we used to use the term medication-assisted treatment a lot, but it sort of implies that the gold standard is some kind of a psychosocial intervention. So the WHO actually recently just put out a statement saying that actually we should be thinking about OUD treatment more as psychosocially assisted pharmacological treatment rather than the medication-assisted treatment. Okay, so in another previous approach, we used to consider that patients who use other substances, so things like cocaine, alcohol, methamphetamines, are not actually good candidates for buprenorphine. So the challenge with this is that polysubstance use is really common, and in our patient population, almost all of our patients use multiple substances. Probably cocaine is a really common one, and speedballing is super common on the street. So, a lot of our patients will use multiple things at the same time, and expecting buprenorphine and opioid use disorder treatment to affect or treat other substance use is sort of unreasonable, because buprenorphine is not used to treat cocaine use disorder or alcohol use disorder or methamphetamines. And really, using other substances shouldn't affect anybody's decision to continue OUD care. And what we find is once we start patients on buprenorphine, patients do come back for primary care, and they do engage in other healthcare maintenance screenings like colonoscopies and mammograms and pap smears. So the new recommendation is that buprenorphine because it doesn't have a direct effect on other substance use, it shouldn't influence care for OUD. So if somebody comes in and their UTOX is positive for cocaine and buprenorphine, we don't typically discharge those patients from our care. We obviously sit patients down and tell them about it and talk about some of the risks. But in general, what we find is that as patients go on buprenorphine and their opioid use disorder is treated, the cocaine use goes down, because they kind of go hand in hand. This is a study that was done by some of our colleagues in the Bronx, which looked at buprenorphine treatment outcomes in patients with opioid use disorder who use cocaine and people who didn't use cocaine. And they looked at treatment retention by baseline cocaine use and then self-reported opioid use among patients who initiated bup treatment by baseline cocaine use. And they really found that there was no difference between whether or not you used cocaine versus if you did use cocaine. And as you can see with the bars, they kind of just all go down the longer you stay in retention, including cocaine use. And then there was this other thought that buprenorphine treatment can be discontinued pretty readily. I think a lot of, when I talk to the residents, a lot of people don't really understand like how long buprenorphine treatment can be used for. Maybe it can just be used for 3 months or 6 months. And in fact, some of the initial studies looking at buprenorphine were studying it as sort of a way to really detox people really rapidly from their opioid addiction, and the outcomes were not great. So really, buprenorphine should not be considered short duration treatment, so like antibiotics. And some patients really do benefit from lifelong or long-term therapy in the same way that patients with diabetes benefit from insulin for a really long time. Some patients can come off buprenorphine in the same way that our patients with diabetes can come off insulin. Some people do, but I think it's a rare minority if you make significant behavioral changes. A lot of our patients still live in the same community, they experience the same triggers, the same people, and so it's really challenging to get out of that environment. And we really have been seeing that relapse rates once you stop treatment really do exceed 50%, sometimes higher. So the recommendation really should just be that patients receive buprenorphine as long as it provides benefit and they want to continue on it. Some patients come to us during intake and they're like, I just want to be on this for 6 months or 8 months. I don't want to come off of it. And we really try to work with the patients, and oftentimes we'll find that over time, patients really do well on buprenorphine and they don't necessarily want to stop it. This is just another study looking at the risk of death during and after opioid use disorder treatment. This is a UK study, and the graph on the figure on the bottom left shows that you don't really get a mortality benefit until after 20 weeks of treatment. So really longer treatment, and ideally, like for some patients, lifelong treatment is most beneficial. So we do have some ongoing challenges related to buprenorphine treatment. There are not enough waivered providers prescribing to enough patients. A lot of people get waivered, but they prescribe to 0 patients, 1 patient, 2 patients. So that's sort of why I think the Department of Health and other states are really trying to figure out what is the best program that we can implement to encourage people to prescribe more. Long-term retention is also really challenging. Our colleagues in the Bronx have 11 years, 12 years of data, which show that really retention drops pretty significantly over 10 years, sometimes down to like 50%. And so what is the best way we can keep these patients in care recognizing that their lives are sometimes chaotic and really challenging. And we don't really have the best model of care to engage these high-risk patients. We've been working really hard at REACH to try to get patients from syringe access programs. Oftentimes these are patients who've never interfaced with the medical system in a primary care setting. You probably know these patients because they go to the emergency department, they're hospitalized for endocarditis, but we're really trying to, through the community and also through our inpatient program, to gain access to this patient population. So, there's a lot of challenges which include polysubstance use and also other coexisting mental health conditions. And I think one of our questions is really how do we practice this concept of harm reduction in a primary care setting when we're not really traditionally set up to do that. Some other models on the horizon that people are sort of experimenting with include collaborative care models for buprenorphine treatment and also group visits. So this is our treatment program at REACH. You guys probably know about it. I'm sorry, some of it got cut off, but we are funded by the DOH to do a nurse care manager model for 3 years. Currently, we have about 70 active patients at IMA who come to us for buprenorphine treatment, some of whom are co-managed with you guys, both the residents and the attendings and the nurse practitioners. And if the workflow is really like if anyone identifies somebody with opioid use disorder through what Trang already mentioned, going down the SBI pathway and then maybe doing a DAST and then doing the DSM5 criteria for OUD. Ask the patient if they're interested in treatment, and if they are, please refer to us, call us. One of the patient navigators, some of whom are sitting right here, will pick up the phone and will come see the patient during business hours. If it's not during business hours, you can email us at reach@mountsinai.org and we will schedule the patient for an appointment. I just want to quickly mention that we have this inpatient program to sort of connect hospitalized patients at Mount Sinai campus to REACH and to buprenorphine treatment. It comprises of a hospitalist attending, Dr. Michael Herscher, who was a resident here, myself. We have a great team of medical students and house staff who are helping us, and our REACH staff. And what we do is that the students actually review a daily EMR report, or the primary teams will refer their patients, but using like a system of different variables, ICD codes, visiting, diagnosis, we're able to identify patients who might have opioid use disorder. And then we evaluate eligible patients in person. We initiate buprenorphine in the hospital prior to discharge. We titrate the dose, and then we do a warm handoff to REACH clinic. So Stacy will actually go to the hospital, meet these patients. She brings like a little goodie bag with like a get well card and a notebook, and then introduces herself, and the patients will follow up in the REACH clinic within a week of discharge to continue their treatment. We've seen about 61 patients so far in person, and about 16 have been started on buprenorphine. Okay, that's it.
Thanks, Linda. So I'm going to take a little bit of a step back in a broader approach and talk some about models of care and how we're trying to work with psychosocial challenges, the psychiatric and substance use comorbidities of the we're working with. So increasingly, there's a lot of attention from a public health perspective on the intersection of opioid use disorder and infectious diseases, HIV and hepatitis C. And really the way these three public health issues are intersecting depends a lot on the local situation, who the emerging injecting drug users are, and the access to things like harm reduction and syringe exchange services. So just as an example, this is basically showing data on rates of any opioid injection among youth, as well as youth defined in two categories, 18 to 29 and 30 to 39 is still youth, as far as I'm concerned, and in relation to HCV rates. And I mean, you can prove causality, but there's certainly a connection that you're seeing. So we have a ton of evidence-based tools for medical treatment, for behavioral treatment, for harm reduction treatment. And really the question is how to get these tools to the patients in a comprehensive way. And that's being attempted at all the points of intersection where these patients are going. So correctional facilities are starting to do Hep C treatment. We're going to be starting a program in a syringe exchange program to do Hep C treatment. We're trying to bring patients into primary care to do Hep C treatment. We go out now to detox and rehab centers where increasingly naloxone kits are being given out. People are trying to engage patients in Hep C treatment and buprenorphine treatment. And nobody's really figured out what is the location that's most effective to engage these patients successfully. But I think everyone agrees that it needs to be comprehensive, and having patients go to one setting for their mental health care, another setting for their buprenorphine, a third setting for their harm reduction equipment is really not effective. So we're trying to do it from the primary care angle, interfacing with the other systems who are, also trying to address this mission, both the ED, as Linda said, the inpatient service, and we work actively with harm reduction programs, correctional health, and mental health and substance use programs. So we have 5 parts of our program. You're familiar with the clinic. Linda talked about Reach In. We have a large outreach program, which is bringing a lot of patients into the clinic who would not be coming into the clinic without our going out to these settings and trying to engage them. We have a set of support groups, and we're involved in research and education. I want to talk a little bit about intersectional stigma. So the concept of intersectional stigma was developed originally by Kimberly Crenshaw, who's a lawyer, and it came out of a lawsuit against General Motors. There was a lawsuit that General Motors back in the 70s was not hiring black women. And General Motors said, we have lots of black employees and we have lots of female employees, but all the black employees were men and all the female employees were white. So in fact, they weren't hiring black women. So often when you look at all these different stigmatized identities, sometimes at the intersection there are unique things going on. So different aspects of our identity are like roads, and those who live at particular intersections experience unique forms of discrimination. And I think I just want to focus in on the intersection between mental health and substance use, because there, as a psychologist, I often the patients with comorbid disorders because that's who I'm most often exposed to. But there is a very important group of patients who have primary substance use disorders who've never seen a psychologist or a psychiatrist, never had a suicide attempt, never been on an inpatient unit, and don't have a psychiatric disorder. And I think a lot of work needs to be done in figuring out the differential needs of these two categories of patients and how we can best work with them. So if you look, nationally at general population surveys, about 40% of those with substance use disorders have a comorbid mental illness in the last year. But if you look specifically at people with opioid use disorders, you'll find much higher rates of psychiatric disorders, So again, in the national sample where 1% of people have opioid use disorders, and again, nationally, most of those people, it's prescription opioids, whereas we see very little of that here. We see mostly heroin use disorder. There was much higher rates of comorbid substance use disorders, as well as higher rates of psychiatric disorders. So 64% of these opioid use disorder patients had a comorbid psychiatric disorder in the last year, and most importantly, 20% had severe mental illness, which is really a third group that probably has a different set of needs. How this relates to the medical treatments we're doing is that, if you look at Hep C treatment, traditionally, Hep C treatment was denied to patients with severe depression, anyone who'd had a significant suicide attempt, because the treatment used, interferon, caused neuropsychiatric side effects, including depression, suicidal ideation, irritability. But for many years now, we've had treatments that do not cause any of those side effects, yet this large study shows that these disparities persist. So even in the DAA era, direct-acting antiviral treatment for hepatitis C, patients with other mood and psychiatric disorders, substance use disorders, are much less likely to be treated. This is on a national basis. So I'm going to skip through this because Linda really covered this. But I think the additional point I would make in terms of behavioral interventions to accompany treatment, particularly with buprenorphine, is that some of the confusion in the literature, some studies finding that behavioral interventions do improve the outcomes, some studies finding they do not. It really depends on the intensity of the medical management. So, for example, in our setting, we have incredibly intense medical management with a physician or nurse practitioner along with a BUP nurse, and in that setting, you might not need additional psychosocial counseling. Nonetheless, and this is just a point for language, this recent report that came out nationally actually wants to do away with medication-assisted treatment and call it medication-based treatment, to take away the idea that you need this counseling. Nonetheless, there might be certain patient groups that would benefit, and this is a study that looked at a national commercial claims database to look at adherence to BUP treatment, commercially insured patients, and they were looking at 90-day medication possession ratio, so they could look at refills and whether the patients had their buprenorphine for 90 days. And in this sample, at least, they did find that patients diagnosed with major depressive disorder or bipolar disorder were less likely to adhere to the buprenorphine. So that could be a group that might need additional counseling. Let me see if I have time to show you our data, maybe quickly. So how do these psychiatric substance use psychosocial factors intersect with the work we're doing? So if you look at the patients we treated between 14 and 18, 333 patients for Hep C, 92% of them completed Hep C treatment. But only 75% of that 92% returned to find out if they had been cured, right? So you have to come back 12 weeks after the end of treatment. So if this were, and of those group who returned, 97% achieved cure. So that's how effective these treatments are. But if this were a clinical trial, we would basically have to report an intent to treat of 67% because so many patients did not come back to find out if they've been cured. So one of the things we were interested in order to improve upon this is what are the characteristics of those patients who are not returning? So we did univariate analyses, but let me jump ahead to the multivariable. So we looked at a host of different factors to see what would predict who returned for their SVR12. So the factors that came out significant were namely two factors. One was whether or not the patient had Medicaid as opposed to anything else. Patients who had Medicaid were less likely to return. And the other factor was stage of liver disease. So patients who had more severe liver disease were more likely to return. And we are now engaging a lot of patients in Hep C treatment with early stage liver disease. So that makes it clear to us that we have to do a better job of educating patients about the importance of returning because I think a lot of patients with early stage liver disease perhaps are thinking that just completing treatment is adequate. Just to go back for a moment to treatment completion, you'll notice there are two variables there that were significant, and one was housing status, right? So that ties back to Andy's work and lecture on Tuesday. So patients who were unstably housed, not surprising, were much less likely to actually complete treatment. And we actually work with a very high percentage of patients who are unstably housed. And the other thing that was related to that was panic disorder. In the last month, those patients were also less likely to complete treatment. Often those patients are afraid to go on the subway or the bus and not able to come into clinic. Okay, so in conclusion, we want to find better ways to work with unstably housed patients. Again, questioning if this is the right place to be working with those patients. Maybe those patients should be treated for Hep C in their homeless shelter. Some people are starting to try to do that work. So, this is not just to inform us how to do better, but also to figure out, as Linda was referencing, who are really the patients that are appropriately treated in this primary care-based program. And with that, we don't have time for our case, but we're just going to give you our contact information and acknowledge the huge team of people working with us.